Hi, I'm Stephanie.
Hi, I'm Adriana.
Hi, I'm Jorge.
Hi, I'm Camila.
And we're group number 23. Today we will be talking about methicillin-resistant Staphylococcus aureus, specifically in the neonatal intensive care units. MRSA remains the leading pathogen for hospital-acquired infections in neonatal patients, showing significant mortality and morbidity. Equipped with remarkable genetic flexibility, MRSA has successfully developed resistance to an extensive range of antibiotics, including vancomycin and antiseptics. In the face of these new challenges, our system of anti-infective strategies is very limited and largely dependent on prevention measures. Active surveillance cultures of MRSA, followed by decolonization and prophylaxis used as a treatment method, may be a promising approach to control MRSA infections with its efficacy and safety in the specific population of neonates.
Our presentation will be in the following order, beginning with clinical manifestations, then pathogenesis, microbiology and resistance, screening and containment, risk factors, immunological response, treatment, discussion, and conclusion.
68% of MRSA-infected neonates presented with local signs such as erythema, purulent discharge, tenderness of wounds or endovascular catheter sites, and fever. Respiratory distress occurred in 28% and septic shock occurred in 6.8%. Approximately 1 out of 5 neonates colonized with MRSA may develop an infection with a median time between colonization to the onset of infection ranging from 4 to 9 days. Vancomycin is the empiric antibiotic in neonates presenting with sepsis and extensive skin infections. However, the reduced susceptibility of vancomycin to MRSA poses a great challenge for anti-infective treatment in neonates. So far, the best strategy to manage neonatal MRSA infections lies in prevention rather than treatment. According to the Canadian Journal of Infectious Diseases, the most common MRSA strains isolated in neonatal wards belong to sequence types 1, 5, 8, and 22. Many of these clones are characterized by the ability to form biofilm, toxin production, and genetic flexibility. The clinical manifestation of MRSA infections may range from mild focal infections such as conjunctivitis and skin and soft tissue infections to more severe forms like toxic shock syndrome and even invasive infections such as sepsis, necrotizing pneumonia, meningitis, endocarditis, osteomyelitis, liver abscesses, and urinary tract infections. A study showed 9 cases of neonates with sepsis due to MRSA had central venous catheterizations within 1 week before being colonized, suggesting that central line-associated bloodstream infection rates increase in preterm infants because they are managed at young gestational ages with naive immune systems and incomplete bacterial microbiome development. The intestines of adults are generally occupied by established microflora, which prevents the colonization of newly incorporated bacteria. In contrast, the intestinal microflora of premature neonates admitted to the NICU is not yet established, and the bacterial profiles and feces of neonates have also been shown to change during the course of the lactation period.
Staphylococcus aureus is bacteria that constitutes our normal flora. It is in our skin, hair, noses, throat, and genitalia. However, Staph aureus is considered to be an opportunistic pathogen. Deep wounds, surgical implants, skin infections, and burns are considered to be major routes of infection. This infection could cause complications such as boils, skin abscesses, and pneumonia, needing antibiotic intervention. This bacteria is able to cause these complications by evading immune responses, by adhering to host tissue and accumulating in a self-protective film. Gene evolution has driven Staphylococcus aureus to undergo point mutations, dividing it into methicillin-sensitive Staph aureus, which is susceptible to antibiotic treatment, and methicillin-resistant Staph aureus, which is resistant to most antibiotics. MRSA can be further divided into 2 strands: hospital-associated MRSA, which mainly affects neonates and older patients and most commonly causes pneumonia-related infections, and community-associated MRSA, which mainly affects young patients and the majority of the time is a skin and soft tissue infection. MRSA is resistant to antibiotics mainly because of its cell wall. The most commonly used antibiotics for MSSA work by disrupting cell wall synthesis. These antibiotics contain beta-lactam rings, which bind to penicillin binding proteins that are responsible for cross-linking of peptidoglycans, thus preventing bacterial cell wall synthesis. However, MRSA is resistant to these antibiotics because of the presence of PBP2A, an altered penicillin binding protein that has a low affinity for beta-lactams. This protein is activated when the cell's normal penicillin binding proteins are blocked, completing the cross-linking of the cell wall.
Studies have reported that containment and termination of transmission are achievable in a neonatal intensive care unit setting. For example, a study performed in Israel that was published in August of 2018. We will be discussing their screening and containment methods. In this study, 5 cases of MRSA were observed, suspected from 2 other patients in the pediatric unit at the time. Pulse field gel electrophoresis was used for molecular typing. The strains from the NICU varied from those of the other 2 hospitalized patients. The routine screening procedures in place for detection of MRSA consisted of screening each admission from other hospitals, as well as screening patients with mothers who previously had MRSA. MRSA was isolated from nasal and rectal swabs. After the outbreak, all patients in the NICU were screened with samples collected from nares, axilla, groin, and anus in each case. The screenings were performed 3 times each week and ended a month after the last colonized infant was discharged. In addition, medical staff and parents associated with the first case were screened once. The outbreak was contained by implementing an emergency policy which indicated using strict isolation through separate rooms and contact precautions. Gloves and gowns were of single use per patient and disposed of after any contact with affected patients. A separate nursing team was assigned to treat only MRSA-affected patients and were not allowed in any other NICU areas. Strict guidelines for infection control remained in place for another month after all positive cases were discharged. The authors credit the successful containment due to the implementation and adherence of strict infection control measures and active screening, as well as a strong communication between staff, the infection control team, and families.
Risk factors for colonization with MRSA in the NICU include infants born with less than 32 weeks of gestation, very low birth weight, prolonged hospitalization, invasive procedures like endotracheal intubation, central venous catheterization, and surgical procedures, and antibiotic use in the NICU. The normal flora protects against pathogens by competing more efficiently for nutrients, by producing antibacterial proteins, and by stimulating immune responses which act to limit pathogen entry. The host minimizes contact between the bacteria and the epithelial cells of the gut lumen by production of mucins and by effector molecules including antimicrobial peptides and secretory IgA. The initial interaction with epithelial cells is governed by toll-like receptors which produce soluble mediators including cytokines, chemokines, and antimicrobial peptides. The soluble mediators recruit neutrophils, macrophages, and NK cells. Local dendritic cells migrate to the lymph nodes and fine-tune the adaptive immune response. The adaptive immune response kicks in later during the course of infection. Antibodies and T cells can have direct activity against bacteria. Most importantly, it amplifies the activity of innate immune cells. This pathogen avoids phagocytosis by expressing on its surface a number of complement inhibitors which prevent host opsonine from binding to the bacteria. It resists neutrophil killing by secreting CHIP, chemotaxis inhibitory protein, and EAP, extracellular adherence protein, which blocks neutrophil recognition of chemotactic factors and neutrophil binding to adhesion molecule ICAM1. Neonatal neutrophils express low level of cell surface L-selectin and MAC1 which mediate the adhesion and tight binding of neutrophils to vascular endothelium, leading to a 50% reduction in neutrophil migration. Also, neonates present immaturity in their lymphocytes, low number of effector memory T cells, impaired Th1 cytokine secretion, and reduced strength of B cell receptor signaling. Mupirocin is a topical antibiotic utilized for the treatment of superficial SRS skin infections and for the decolonization of nasal carriers. A current study aimed to evaluate the effects of monthly intranasal mupirocin prophylaxis administered to NICU patients on MRSA transmission and invasive SRS infections. Starting on December 9, 2013, all patients participating in the study received mupirocin to the anterior nares twice daily for 5 days with the treatment being repeated every 5 weeks until December 31, 2015. After the implementation of monthly mupirocin prophylaxis, healthcare-associated MRSA transmission decreased by 45% and SRS infection decreased by 73%.
Upon admission to the NICU, the duration of stay and birth weight showed statistically significant differences between non-MRSA colonized neonates and MRSA colonized neonates, with median length of stay at 28.9 days, median birth weight at 2,459 grams, and a median gestational age at 36.3 weeks. As far as procedures go, central venous catheterizations proved to be the most statistically significant risk factor for MRSA infection. Digestive system diseases showed marginally significant differences for MRSA infection. It has been reported that the feces from MRSA carriers contain the same clones as the nasal isolates in considerable amounts, suggesting that more careful attention should be paid in handling of feces in neonates than adults. It has also been reported that prolonged empiric antimicrobial administrations greater than 14 days for neonates results in adverse consequences, including late-onset sepsis and necrotizing enterocolitis. Recommendations include discontinued use of empiric antimicrobial administration within 7 days. The significance of education and adherence to guidelines of healthcare providers to reduce central line-associated bloodstream infections is crucial since the main risk factors are poor compliance with hand hygiene and use of sterile precautions during insertion and manipulation of central lines. Apart from surveillance and decolonization of neonates, other measures that may contribute to prevention of MRSA infections include cohorting and isolation of MRSA-positive patients, barrier precautions, and surveillance and decolonization of healthcare workers and visiting parents. Enhanced survival rate of very immature preterm infants may contribute to a growing population of infants at risk for MRSA colonization and subsequent infections. The CDC and HICPAC guidelines for infection prevention in the NICU recommended the minimization of the duration of central venous catheterization, intubation, and antimicrobial agent use for neonates in the NICU, particularly those with low birth weight, young gestational age, multiple gestation, and MRSA colonization. The CDC emphasized the importance of education of all healthcare providers and families to prevent MRSA transmission.